kicked off. Instead, we'll have Dr. Hill go ahead and jump in here momentarily. I will start off by doing a little housekeeping. I will be muting everyone's mic during the presentation. At the end of our, and we really haven't talked too much, Dr. Hill, about questions, but typically what we do is ask folks to use the chat function, which you'll find at the bottom of your screen. Generally, it's 2 or 3 icons, 3 or 4 icons from the left. You'll see chat. You can click on that, and you'll have an opportunity to type in any questions you may have. I will moderate the questions when we get to a Q&A period at the end of the presentation. So with that, we want to thank Dr. Hill, who is an associate professor at the University of Cincinnati. And she has actually done this basics of PD once or twice before. She does an excellent job. This is one of our most popular PD EDUs. If you are unfamiliar, we do an educational webinar approximately 10 months out of the year, usually in the middle of the month like this on a Saturday morning starting at 11 a.m. Typically, they only go 11 to 12. However, today's presentation includes not only Dr. Hill's presentation and discussion, but we also have a panel of folks with Parkinson's who can speak to their learning that they had Parkinson's, what that felt like, and maybe more importantly, how their journey has progressed in the years since. So we'll take some questions after Dr. Hill's presentation, maybe a quick bio break, and then we'll have our panel. So instead of 11 to 12, we're going to go 11 to 1 today. And without further ado, I will introduce Dr. Hill.
Hello, thank you so much for having me. It's a real compliment that so many of you have logged on, so I really appreciate it. So I will go ahead and share my slides here. Thank you for introducing me, because Maureen is with Lila. That's my 3-year-old. Do this here. Go back this way and share. And it is okay to interrupt me if you find there are questions in the chat, before the end of the presentation. I'm okay with being interrupted because I do want to make sure I'm covering what you all are most interested in. So this is kind of my way of thinking about the basics, but if I'm off base, I want to know. So let me see here. Okay, great. I think this will work. This is sort of a different view. Okay, so my goals today are I want to talk about how doctors think about Parkinson's disease. I want to go through how the diagnosis is made. And I do have a couple of updates compared to the last time that I gave this talk because there have been a couple of new tests. So I'll talk about those and happy to go into more detail if people want. I want to talk about the symptoms of Parkinson's disease and the treatment. Those to me are the most important things. Okay, Parkinson's disease is important. This is a syndrome that is getting more common as the population ages. So when people ask me what I do, it's pretty common for them to have a personal connection to Parkinson's. They know someone who knows someone because as our population is getting older, more people have Parkinson's. So you see here that aging is the strongest risk factor. It's 1 in 100 people over 60. And then by the time someone's 85 years old, it's 5 in 100 people. And so we're still learning about risk factors and why that is, but we know that aging is the most important risk factor. Parkinson's disease was first described in the year 1817. So this I guess not that long ago, celebrated the 200-year anniversary of James Parkinson describing a person with Parkinson's disease. It really had not been described before that. Notably, Shakespeare, who described everything he saw, did not describe Parkinson's. So we wonder if there was some change in risk factors around that time. This is how we think about Parkinson's disease in the body. We know that there's a part of the brain, the midbrain here, that there's an arrow here, so deep in the brain, that starts to lose cells. So these cells, I don't know if you can see my cursor. Um, you can,
Yes.
okay. So these cells here, when they're healthy, they're dark. And as we start to lose those cells, you lose that darkness there. And these are the cells that make dopamine. So Parkinson's is complicated. There's a lot of chemicals that are not quite right in Parkinson's, but dopamine is the main one. We see that these cells, when you zoom in with a microscope, you can see that they don't look quite normal. This pink circle here is called a Lewy body. So this is alpha-synuclein, which I'll talk more about. That's the protein that we know is most abnormal in Parkinson's. Has clumped up here and it's made a Lewy body in this nerve cell. That brown stuff is melanin. So that's why these cells look dark. So this, if you didn't have that pink dot, that would be the healthy nerve cell. Okay, so that's what we know about Parkinson's disease brain when we study the brains of people with Parkinson's. And again, the main thing that we know is that dopamine is low. So there's these little greenish dots represent dopamine moving from one nerve cell to the next. And we see that the brain with Parkinson's disease is moving less dopamine to the next cell. And that causes lots of symptoms, but the ones we recognize initially are the movement disorder symptoms. Okay, what causes Parkinson's disease? We don't really know. We know it's some combination of genetics and environment, which is what doctors say for most diseases, honestly. About 1 in 10 people with Parkinson's disease are found to have a risk factor for in their genetics. So when you do their DNA testing, you can see that their risk of Parkinson's was increased by their genes. And then we know there's environmental risk factors, people who are exposed to Agent Orange. In Vietnam, our veterans had a higher rate of Parkinson's disease. We know that certain pesticides are associated with increased risk of Parkinson's disease. And we know that manganese, so welders who are exposed to manganese have an increased risk of Parkinson's disease. So there's got to be some kind of complex web of risk factors, and that's why people get Parkinson's. And also something about gut bacteria. We know that constipation, for example, tends to show up many years before Parkinson's disease. And so there have been several research studies trying to see if we can stop the disease if we treat the intestines first. So that's ongoing, but no successes there yet. Okay, next I go into how is the diagnosis made? So people ask me, how do you know I have Parkinson's disease? Step one is I hear the Parkinson's story, I call it. So there are a list of symptoms that are very common for people with Parkinson's, including those that show up long before any movement disorder. So when I hear the story, I'm hearing the symptoms, I'm thinking, okay, this is probably Parkinson's disease. Then I confirm that with the physical exam. So the physical exam is how we meet criteria for Parkinson's disease. This is the standard diagnostic criteria, the Parkinson's UK Brain Bank. So meaning they got a bunch of people with Parkinson's who donated their brains to science. When you look under the microscope, you see what they all have in common, which are those Lewy bodies and loss of brain cells in that substantia nigra. And then when you look at what they had in their symptoms, that's how we made the diagnostic criteria. Okay. So the story, it usually starts on one side, the movement disorder or the tremor. Not everyone has tremor. It's not required to have tremor to have Parkinson's disease. Um, and so, oh, let's see, we have a question. What non-motor symptoms do you see in a new patient? Okay, yeah, I'll get into that. Decreased smells and non-motor symptoms. So usually I'll ask if someone else in the room would notice a bad smell before them. Constipation, like I said, long before the motor symptoms. dream enactment behavior or REM sleep behavior disorder. So it's usually a violent dream or like a really bad nightmare where people are fighting, swinging, running, that kind of thing. So these are the non-motor symptoms that often will come many years before any Parkinson's symptoms. And then rest tremor. And then another, if someone has tried the medicine before they meet me, if they respond to the medicine, that's very supportive. And then if someone comes to me and they've had symptoms for a long time, and by that we mean 10 years or more, it's usually because of Parkinson's disease. It doesn't tend to be one of the cousins of Parkinson's that does that, and I'll go into that as well. These are the cousins of Parkinson's. That's what I call them. So Parkinsonism means Parkinson's-ish. So you have some symptoms that look like Parkinson's disease, but maybe you have a couple other things that make us wonder if that's truly Parkinson's. So over the years, we've studied more brains of people under the microscope and found there are some people who share Parkinson's symptoms, but their brains look a little different under the microscope. And so that's how we got these cousins of Parkinson's. You got dementia with Lewy bodies, multiple system atrophy. These also on this side, these are the alpha-synuclein, that same protein that's abnormal in Parkinson's is abnormal in these ones, just in a slightly different way. And then we got PSP and cortical basal syndrome over here. That protein is tau that's abnormal primarily in those. I wrote under here, there are a couple things that can mimic Parkinson's disease. These are quite rare. And usually I start thinking about these when people don't give me the Parkinson's story. Like they don't, like their sense of smell is fine. They've never had constipation, never had one of those dreams. Maybe there's tremors on both sides and always has been on both sides. I'm like, that's kind of weird. That makes me want to do a brain MRI. But usually I don't need a brain MRI when people give me the classic story and they have the exam findings. Okay, so yes, then I've heard the things, they're meeting criteria in my mind, and so now I'm going to do the examination. So we do the finger tapping, the open close, and the twist twist, and the foot stomps. I'm looking for a very specific kind of slowness of movement. It has to be a abnormal speed, rhythm, or amplitude. So how big is the movement? And so if people have any of those movements are not perfect in speed, rhythm, and amplitude, then they meet criteria for bradykinesia. So that's just the medical term for slow movement. Brady means slow, kinesia means movement. So, and it really is the amplitude or the size gets smaller the more you do it. So usually people notice this in their handwriting. A lot of times that's one of the first symptoms. The handwriting starts out okay, and then the more they write, the teenier and teenier it gets, right? So that's bradykinesia. If you have that, then you need at least one other finding to meet criteria. So that's either stiffness of the muscles, rigidity, rest tremor, and that says 4 to 6 hertz rest tremor. So that's how fast the tremor is going, like 1, 2, 3, 4, 1, 2, 3, 4. People have a very slow tremor, it's usually not Parkinson's, or a very fast tremor, it's usually not. Okay. And then postural instability, that's a fancy way of saying balance problems. That's why we pull you over in the clinic. Sorry. But this is a key factor of one of the Parkinson's symptoms. So if you have at least one of these, you meet criteria for Parkinson's disease. So usually after the history and examination, I can give the diagnosis. They found that when experts, so people with training in movement disorders, do the history and examination, that's very accurate with what we see under the microscope. It's like, in the 90% accuracy. So that's why I don't usually need any more testing because they've shown that when you see these symptoms and examination findings, it's Parkinson's. But rarely after the exam, I'm not 100% sure. Sometimes people will have, maybe they have like a really bad spine disease. And so it's hard to know if that's why their muscles are a little tight or they're, like I had one patient who was missing an arm actually. So I couldn't test for slowness on that side. So things like that. Well, sometimes I need more tests to help me understand what they have. So we have this thing called the dopamine transporter scan. This is a brain scan. It's a couple of CAT scans. After we give an injection, to mark the dopamine cells. So those cells that I showed you in the, first couple slides, one of the ways we can check if they're healthy is, are they sending their signal up to the middle of the brain? So they're from deep in the brain up to the middle. So that's what we're looking for here. We can see people who have no Parkinson's disease have this nice comma shape. That means the cells are healthy. When the cells are starting to die, they go away in the tail of the comma first. So when those cells go away, it makes like a period shape rather than a comma shape. And so that's how we know if someone has low dopamine in the brain. So that we have a computer program actually that reads it for us, which is nice. This is a very clear example, but sometimes it's subtle. And so a computer program will read it and say yes or no abnormal. Some of the Parkinson cousins can have an abnormal DAT scan. So this just means low dopamine. But if I'm not sure if somebody actually has low dopamine, this can help me. Okay. There's a couple of newer tests. So these are ones that we're using in some cases. I still usually pick the dopamine transporter scan first because it's tried and true. And it's usually pretty easy unless people are very claustrophobic. Usually pretty easy. There is a spinal fluid test. So that's when you get a spinal tap and they take the spinal fluid out through the low back, which is being shown here. And so basically what we're looking for is the abnormal protein, the alpha-synuclein, is that present in your spinal fluid in a way that looks like Parkinson's? So we're seeing if we can make that protein clump up. When the protein is loose, it's functioning, it's healthy, it's a normal protein. When it clumps up, it's abnormal. So we're saying, does your fluid have the clumpy kind of protein or the healthy by itself protein? So that's what they do here. They actually they jiggle it in the lab to see if it clumps up. Excuse me. So that is, you'll hear this called the seed amplification assay, or SynTap is the brand name for it. Another test we've been doing is the skin biopsy. So I actually do these in clinic. These were developed through the Michael J. Fox Foundation study, which some of you may be involved in, the PPMI. So we have been doing those for research purposes, and then recently they found you could see the alpha-synuclein in the skin in a way that was pretty accurate for Parkinson's disease. So this is a picture of a microscope here, um, or microscope picture, I guess, that shows the alpha-synuclein in the skin. It's a small sample. We take 3 samples, but it's pretty small. It's like they say a pencil eraser, but it's even smaller than that, really. And so we take 3 of those, and you see here the numbers. They're quite accurate for the Parkinson's disease, and then the cousins of Parkinson's that involve alpha-synuclein. So that's MSA, dementia with Lewy bodies. This one here is primary autonomic failure. That's pretty uncommon, but that's people who have severe blood pressure drops as their first symptom. Okay, so that's the skin biopsy. Okay, now what? I made the diagnosis and maybe I needed some tests to confirm it, but not usually. But now I've told you you have Parkinson's disease. Now what do we do? Most people say, okay, doc, what stage am I? Parkinson's disease really doesn't have stages like cancer does. Cancer has some nice, easy to understand stages, but Parkinson's really doesn't have that. If you Google stages of Parkinson's, you'll see the stages we use for research, which really just has to do with walking difficulty. Like, do you need a cane or a wheelchair? That's really the only stages we have. But we know Parkinson's is much more complex than that, so that's not really that useful. Yeah, so technically this is what you'll find if you Google the stages. It's just like how much walking trouble is there. So what I tell people is everybody's different. Usually when they're asking me that, they're like, what can I expect? What is my future? What's going to happen to me? And I say, I don't really know. I'm just along for the ride with you. We're going to find out together, but I'm here for you. Some people have very rapidly progressive symptoms. That's very rare. Most of the time, people have a very slow progression of their Parkinson's disease. And I say where we've been shows us where we'll go. So you look at the past to help predict the future. If your symptoms are getting slowly worse, that's about the rate they're going to continue to get worse. And so these are examples of different people with Parkinson's disease. What's important to remember, people ask me, is this going to kill me? And I say, no. I mean, they've shown that people with Parkinson's disease, especially if when they first develop symptoms, they did not have dementia. There are some people who have dementia when they are first diagnosed, but those people who don't have dementia when they're first diagnosed have a normal life expectancy. They're expected to live just as long as anybody else. Okay. This is a famous picture that we use to teach all the students and residents about how fast Parkinson's disease progresses. So you see many years before the motor symptoms start. This is when we say you have Parkinson's, this is the first time there's a motor symptom. That can be decreased hand or smaller handwriting, decreased arm swing, tremor, anything like that. Anytime that the mobility symptoms begin, that's when you start Parkinson's. Prior to that, you have years of constipation. This is the bad dreams, the REM sleep behavior disorder, low sense of smell or mood disorders. Okay. About 10 years in is when most people are having more symptoms. And so that's why we make that distinction about the 10 years. By the time you're at 20 years, a lot of people are having more symptoms. They're having more cognitive problems. They're having trouble swallowing, falls, things like that. We've seen people break those rules. We've been surprised many times. But this is sort of, if you average everybody, this is a lot of what you see. Okay, next I have treatment. First of all, exercise. Exercise protects the brain. We actually have a mechanism. We know why it works. It increases chemicals in the bloodstream that will protect brain cells. So your body makes these chemicals to increase the health of your brain cells, and you can boost them with cardio. And actually, we just found out too that weight training is really good for you too. So we all looked at each other at our last sunflower symposium and said, okay, I guess we have to do weights now too, because we're all doing it too. Anybody who knows about Parkinson's does a lot of exercise because we know how good it is for the brain. So you see here that the motor symptom scores, when I do that physical exam with the tapping and the open close, um, that gets a number score. And so some people I will just prescribe exercise and they come back and their number score is better. So that's very impressive. We're very into that. This is a pretty intense prescription for exercise. 80% of the max heart rate is uncomfortable. That's really working out hard. And it's 5 days a week is a prescription. So that's pretty intense. They are currently studying if it needs to be quite that intense. So we know that, big time intense exercise, very good for you. They're testing now, can you do just regular cardio and see how you do? So hopefully soon I'll have the results of that study. A lot of people ask me what kind of exercise. I say anything you like to do. It does not matter. I mean, we find that people who get an exercise buddy tend to do very well. So, because you need somebody, I mean, I personally need this. I really need somebody to be like, where were you? That's the only time I actually do the exercise. And so any kind of exercise is good. We love the stationary bike because people feel safe on that. The treadmill has been shown to be safe for Parkinson's, so as long as you're careful, that one's good. Some of my patients love swimming, especially for shoulder mobility. That's a real problem in Parkinson's. That shoulder tends to lock up because it's not swinging all the time. That keeps the joint lubricated to swing your arm all day. And so when your joint stops doing that, it gets frozen shoulder. And so swimming, people like that. And then of course, we love the Parkinson's boxing. I love seeing videos of my patients at Parkinson's boxing. So that's a lot of fun. And that one has the social benefit too, because it's a lot of people who understand Parkinson's who are also doing the boxing. So that's the rock steady boxing. So, but the short answer is I don't care what kind you do as long as you do something. Okay. Then for people who are ready to start a medication, basically I'm giving back dopamine in pill form. So the pill is Cinemet is the brand name. That's carbidopa levodopa. Sinemet, sin is without, emet is emesis or vomiting. So the reason it's called Sinemet is because levodopa, if you give it by itself, makes people throw up. So we add the carbidopa to prevent nausea. Some people still get a lot of nausea with it, so sometimes we add more carbidopa. Okay, this is like the sister to the levodopa. Okay, so little yellow pills that you all know and love. My patients joke sometimes they're going to string them up on the Christmas tree because they get too many of them when we give you a year's worth of supplies. Okay, so then there's Rytari, which is a capsule form of carbidopa levodopa. One of the big problems you're all aware of is the Parkinson's meds will last for a short time. This is a short-acting medication. So we're always trying to do new things to make it last longer. So they first came out with Cinemet CR, controlled release, but that interacted with food a lot, didn't quite work. But if you put it in a capsule and combine it with immediate release, it's Rytari. It's a nice gentle form of carbidopa levodopa. That's how I think about it. I give it to people who don't tolerate regular Cinemet. We've got the intestinal gel. We've got a couple of new pills. We've got a brand new treatment out that goes into the skin. That's an infusion into the skin to make it last longer. Dopamine agonist. So we've got a whole list of medications. That could be a talk in and of itself, but if people are interested, I can go into more detail. Some general tips for levodopa. People ask me this a lot. Okay, do I have to take it on an empty stomach? The answer is don't worry about it too much. Technically, yes, an ideal situation is the stomach is empty, you take the pill, and then 30 minutes later you eat. That's an ideal situation. That's not required. Some people are like, they need the medication pretty frequently and they're so stressed out about trying to take it on an empty stomach. I said, don't worry about it, guys. Don't let it rule your life. But some people tell me, hey, I had a rough Friday night and I just like, I'm struggling. I said, did you eat steak? And they say, how did you know that? Because technically the medication can interact with protein where the protein's competing with the medication. So that's why they say the protein interaction thing. Some people try to change their whole diet and make it low protein in general. So I don't think you need to do that unless you're telling me, man, this carbidopa levodopa does nothing for me. Then we start to be like, well, maybe you're eating too much steak or something with too much protein. So yeah, the pill is best absorbed in the very first part of the intestine. So you see just outside the stomach here is the first part of the intestine called the duodenum. And so our goal is to get the pills into the duodenum and then seal it by eating. So that's the trick there. Again, this is short acting. So usually when you hear a medicine is 3 times a day, which is what we start off with these pills, but usually when you used to hear that, that was like for an antibiotic or something, right? So that meant morning, middle of the day, bedtime. Parkinson meds are not really like that because we want it to be working while you're up moving. So we say around meal times, like breakfast, lunch, dinner. A lot of times we do add a bedtime dose of that controlled release. Maureen taught me that. She used that a lot. So I started using it more with my patients and people like it. Um, it doesn't work during the day so much, but if you make it really consistent at bedtime, it can really help. But anyways, other than that, we like it to be kind of during the day. So those are some general tips for taking the levodopa. Levodopa myths. A lot of people used to be afraid of taking the meds. And so we call it levodopaphobia. People were afraid you could like get addicted to it or that it would eventually stop working for you or that you would get dyskinesia the longer you were on it. That those extra wiggly movements like Michael J. Fox. And so we found over the years that you don't need to be afraid of carbidopa levodopa. It does not cause more side effects the longer you're on it. As the brain loses more dopamine cells, it needs more dopamine to be given back in pill form. But it's not because of the pills, it's because of the Parkinson's, if that makes sense. And so they found that people who never took any meds, but had had Parkinson's for many years. So this was done in Africa, one of more recent studies. Nigeria has a really big Parkinson's clinic. And unfortunately, they had people who just had no access to Parkinson's care. And when they got their first dose of Sinemet, of carbidopa levodopa, they had dyskinesia. So it wasn't that they've been on the meds for years and years, it was that they've had Parkinson's for years and years. So I think that's important for people to know. And again, dyskinesia, we call it the price of success. It just means the meds are working. A lot of times people hate it, but most of the time people don't notice it as much as others notice. They prefer to be on and wiggly than off and stiff. So yeah, okay. Here's a little chart here that shows that we did a research project. This is Dr. Espe from our clinic and Tony Lang, his mentor, about how levodopa improves quality of life. So if you start it earlier, people tend to have more productive years in their life, right? They can do more that they want to do because they're on the meds. So I'm pretty aggressive. I recommend it. I mean, if people don't want to take meds, I'm like, okay, as long as I don't think you're going to fall, you don't have to take meds. But once people are really bothered, especially if people are still working, I'm like, man, I really think you need the good stuff. I think you need levodopa to feel better. And so we try to get that to improve overall quality of life. Deep brain stimulation, people ask about this a lot. So this is a surgery that acts like having medicine in your system all the time. So you see here, this is going deep into the brain near where the neurons, the dopamine cells, are sending their signal. And so we send electricity deep into the brain to kind of break up the bad circuit that's causing tremor and rigidity and slowness. Okay. So this markedly reduces how much of the medication by pills that you need. So people who are needing the pills all day, every day, they maybe get 2 hours where the pills help them and they need more and more and more. This surgery is very, very beneficial. We typically have people awake, but they've shown recently you don't have to be awake for it. So we offer it asleep. And then another thing it would treat is if the tremor is very severe, very big, sometimes the meds don't touch it, but the brain stimulator will. So that's DBS. Parkinson's disease causes all kinds of symptoms. I can relate almost anything to Parkinson's disease. Mood disorders, feeling cold all the time, sweating for no reason, lightheaded, even feeling short of breath. There's stiffness of the muscles in between the ribs, like going to the bathroom all night, constipation. Like it's just a huge list. And so a lot of what I do is try to focus on what is bothering people the most and see if I can help. But yeah, Parkinson's is a whole body syndrome. It affects so many things. So a lot of times I'm having to talk to the primary care doctor and like, yes, please rule out anything that would be life-threatening, right? Like do your job, do your tests. But if those tests don't reveal anything, yes, it's true, Parkinson's can do that. And then here are other things I work on in the clinic. We've got lots of treatments for constipation. I'm very aggressive about constipation. It's just like a silly thing to end up in the hospital for. So I'm like, not on my watch. I mean, because the constipation can get really severe and it can really cause problems. People get confused. You're more likely to get a urinary tract infection. Obviously, it's quite uncomfortable when you get really stopped up. So I am very aggressive. I tend to pick the stool softeners. Miralax is great, and Metamucil is great, but it needs a lot of water to actually work. And a lot of times my Parkinson patients don't love to drink water. So we use the stool softeners. I got my fancy recipes that I'm happy to share with you all. There's the fiber recipes. It tastes like a fig Newton. So yeah, sleep problems super common. So we first have to make sure everybody's doing all the stuff we know you're supposed to do. So we know we're supposed to make a big deal out of bedtime. You know how you do that for toddlers. We've been talking about toddlers. You got to make a huge deal out of bedtime, make it a big routine, and then you kind of really wind the brain down that way. Turns out you still need that when you're a grown up. But people ignore that and they sit up watching TV and then they try to turn their brain off and it won't do it, right? So if you make a big deal out of bedtime, we're going to wear pajamas. We're going to put on the fancy lotion that smells good. We're going to do something to calm down. All those things are really important to help your brain go to sleep and stay asleep. And then I do have medications we use a lot. We got sleep is very important, so we help people get to sleep. So anyways, and then fatigue separate from being sleepy, we work on that. Apathy, that's a hard one. You just don't feel like doing much. You're not depressed, but you just don't want to do much. So that is, we got to set small goals for that. We got a lot of things for that. Overactive bladder, that's a rough one. We got medications for that. Rarely we can do botulinum toxin injections. Not we, I have the urologist do that, but I can refer for botulinum toxin injections to calm down an overactive bladder. And then confusion and hallucinations, we have medications that help quite a bit. Some tips for care partners. This is a slide I took from Maureen, super important. You need a support system. This is not the time in your life to be quiet. This is the time in your life to ask for help. People need to know that you need them. We're humans, we need each other. So it's time to be vocal. It's time to ask. You do need to take time for yourself. You need to do whatever it takes to, make sure you are getting out of the house and taking care of your basic needs as well. And then you can do small tasks that others can help with, because sometimes people say, like, let me know how I can help. And it's kind of hard to know how to direct people, or like, so little small things it'd be nice if you had help with, especially little chores around the house. It's very important to remember that what you're going through is unique to you. So sometimes the support groups are super helpful, obviously, but sometimes people get caught up in what other people are going through and comparing themselves. So I always encourage people to not get caught up in that. And then you got to be really aware of yourself. What is it that sends you over the edge? What is it that is going to be your canary in the coal mine that you need a break? And so make sure that you're taking care of yourself. And then we love, you know, going to therapy. We think is super important. We do have an excellent social worker who is seeing some therapy patients, but nowadays it's getting more accessible, talk therapy. So we do recommend that. And then, we can help people look at their options for hiring some help so that they can get out and go to their own doctor appointments, things like that. We do say focus on the positive when you can. That's really helpful. We try to, I think that's where the support groups can be helpful too, supporting people in seeing the good. Yeah, and then just being kind. Nobody's supposed to be perfect, including as a care partner, right? So just be sweet to yourself. Okay, and then we are doing research at University of Cincinnati. We're doing a lot of cool things. We're trying to do personalized medicine. The one size fits all for levodopa is fine because it helps motor symptoms, but we haven't cured Parkinson's yet. It's probably because there are many, many Parkinson's diseases. And so we're trying to find out who is high or low in what, marker in the body, and then figure out what they need personally. They need a little bit more of this, a little bit less of that. And so that's how we're going to try to come up with personalized medicine for Parkinson's. I always give people this website to check periodically, clinicaltrials.gov. People ask me, what's the latest? What research is new and hot? And I say, check out clinicaltrials.gov. It'll show you which ones are for Parkinson's and if they're recruiting and where they are. And they'll even show you progress reports if they have come up with results. Okay. I am ready for questions. I'll go ahead and stop sharing, I think.
All right, as we mentioned earlier, if you have questions, you can type them into the chat box. You'll find that chat icon in the tool tray down at the bottom of your screens, usually. We've had a couple of questions already come in. Denise asked, at what oral dosing of Cinemet do you tell the patient time to switch to another method?
Great question. So it's not like a certain number of pills or number of doses. It's really just based on the side effects you're having. So if people are needing the medicine very frequently and they're having a lot of dyskinesia and a lot of off time, that's usually when I start to try to look for other methods. So we start with entacapone, which just improves the duration of the carbidopa levodopa. It stops the body from breaking it down. But that can lead to more dyskinesia. So if people are having too much dyskinesia, then we try for Rytari or one of the newer meds. Crexont is one of the newer meds made by the same people as Rytari, but it sticks to the intestine. So we have like less than 10 people on it, but they're seeming to like it. It seems to last longer. So we're trying. But yeah, it's usually when there's a lot of fluctuation, so on and off, dyskinesia, and very frequent dosing. That's usually when I start to try to look for other methods. Okay, can we talk about the new under the skin treatment? Yes. So there's a gel of carbidopa levodopa, and it's in a little syringe, like a little plastic syringe inside a plastic box that you wear in a fanny pack. So it's like, I don't know if you guys can see me, about yay big. It's kind of big. A little plastic tube then goes into the stomach. Not stomach, the belly fat. And so it's a little tiny, like just like the insulin pump for people with diabetes. It's actually from, I think, the same company. So little teeny plastic tube into the belly. So then it infuses carbidopa, levodopa all day and all night. So we're very excited about that. The people who love it really love it. Now, it's pretty common, it makes a welt where the medicine went in. So you have a lumpy belly. Rarely they get infected. You can have cellulitis, but not very common. But the people who love it don't care. Like, I'll take a lumpy belly. I'm never off. Now it's been approved, but Medicare is not covering it yet. So anybody who's not on Medicare is potentially a candidate. You can take it off. They said for if you remove it for up to an hour, there seems to be no bad effects. So people can take showers or swim or whatever. But anyways, yeah, that's interesting. I personally don't have anyone on it yet. I have a list of people who could maybe qualify. Some people say that that box is too big. I don't want to wear that around, or they don't like the idea of the skin bumps. And some people just are interested, but it's not covered by Medicare yet, so they can't get it yet. Okay. Any correlation between PD and peripheral neuropathy? Yes, there seems to be. Boy, we have not figured it out yet. When I went to the last movement disorder conference, there were a couple posters about people who'd had peripheral neuropathy, sometimes very painful peripheral neuropathy, in the fingers and hands, and we can't figure out why. We know that peripheral neuropathy is very common with aging as well. And so some of it might be true, and unrelated, we call it, where it's just like you would have had that anyway. But there seems to be a link with peripheral neuropathy, but it's very poorly understood as of now. I take Cinemet through the night to sleep. What does that hurt? It doesn't hurt anything. No, I do tell people it's okay to take it overnight if they need to. Some of these other treatments might be nice because you don't have to wake up for them. So deep brain stimulation, you're on all night. So you sleep much better because you don't have to wake up to take your meds. Same thing with the skin infusion. You don't have to wake up to take a pill, but it is okay to take carbidopa levodopa overnight. With orthostasis, what's the best blood pressure range to maintain? Oh my gosh, this is such a tough problem. So, Parkinson's disease affects the blood pressure system. For people, when they stand up, for example, your blood falls to your feet, your blood vessels squish together to keep the blood towards your head, okay? When you sit down, the blood vessels relax because they don't have to pump so hard. Stand up, squish, sit down, relax. Okay, this is a dynamic process all day when you're moving. That process is affected in Parkinson's. The blood pressure, the blood vessels stop doing that. So now the blood pressure is all over the place. Oh, we have a whiteboard experience. Cool. Um, so the blood pressure is all over the place. It shoots up very high and it sinks down very low, and it's really impossible to maintain a range. So, because people will for example, they'll have horrible blood pressure drops where we're putting them on multiple medications. Then they'll be admitted to the hospital and they're on antihypertensives because they've been lying down in a hospital bed, so their blood pressure's high. Then they go home and they fall because they're lightheaded. I mean, it's a battle. These people come to me, this blood pressure log, and they're like, Dr. Hill, look at this. It's all over the place. Help me. I'm like, I'm sorry. It's not your fault. It's the Parkinson's. It's all over the place. Okay. So that being said, we don't shoot for a particular number. In fact, I'll often tell people to stop checking their blood pressure because it's just going to drive you crazy because it's all over the place. Now, if there's a symptom that you really want to know if it's blood pressure related, okay, we can check it. Or if your cardiologist says you must check it, don't get me in trouble with any cardiologist, but it will be labile. It will be inconsistent. Okay, so we try to avoid low blood pressures. Those cause more problems. Theoretically, a very high blood pressure is not good for your brain, but in this scenario, it's short-lived. It's a spike rather than staying high all day, every day, which causes strokes and stuff. So we say we prefer the blood pressure to be too high than to be too low. Just stay on the blood pressure medicines that support the blood pressure. Even if you find a high reading, try to ignore it because we know a low one's right behind it. Okay, so that's orthostasis. Is there a genetic marker to test to see if an offspring is at risk? Great question. So again, Parkinson's is so complicated. There are genetic panels that show if there's increased risk for Parkinson's disease, but it's not really all that helpful most of the time. So it's pretty rare that there's a family where Parkinson's runs in the family very strongly. It's more like I think it's 1 in 5 or 1 in 7 people with Parkinson's can think of a family member who had Parkinson's. So that's pretty common. But like a very strong family history, like parents had it, grandparents had it, kids have it, that's pretty rare. So for that, the genetic testing has more benefit. I had a patient once who she got young onset Parkinson's, so more likely to be genetic. Her mother had young onset Parkinson's, got symptoms at the same age. This is clearly a genetic syndrome. We did a genetic panel and it was negative. Like, oh, for crying out loud. So her gene is hiding somewhere. We don't know where it is. So all that to say, I don't routinely recommend genetic testing for people who have family members with Parkinson's, but I'm happy to guide people to a genetic panel and tell them you could still get Parkinson's, but these are the genes. Okay, an average age that Parkinson's starts. I don't know that there's an average per se. We just have that like 65 is where it starts to increase the risk, and then by 85, it's even higher. So usually we talk about people in their late 60s and above. Any progress in stem cell therapy? I'm still waiting to hear. One of my friends from training left medical practice altogether to advise one of these companies who's doing the stem cells. So I haven't heard. Early on, we tried stem cells a long time ago, and people had really bad dyskinesia. It was really rough. So they say they have new methods and it's supposed to be better soon, but the jury's still out. We haven't heard yet. Does Parkinson's affect speech? Very much. Slowness of movement of the mouth and the tongue causes speech problems in Parkinson's disease. Low volume of speech, difficulty with clear words is very common in Parkinson's. So there's a voice therapy or a speech therapy program specifically designed for Parkinson's called Lee Silverman Voice Therapy. And apparently it's just awesome. I've never been to one of the sessions, but people love it. It's really good. So that's the gold standard. But yeah, our speech therapists are very enthusiastic about helping people with Parkinson's. Does stress cause Parkinson's? No, I mean, stress makes everything worse. Stress certainly makes everything worse. So we know that when there's stress, either emotional stress or like an injury to the body, people tend to need more medicine, honestly. Like they'll notice their Parkinson's symptoms are worse. So we've had people who will have an injury and then we'll say for a short time, we're going to bump your levodopa. And then when you recover, we'll try to reduce it back. But we definitely know that stress makes everything worse, but there's not a clear link that it causes Parkinson's. And then does radiation cause Parkinson's? No, not that I'm aware of, but we still need to figure out all the different environmental or things that can happen to a person, risk factors. Because, like, again, this wasn't described until after the Industrial Revolution. So something's going on, but we have yet to figure that out. Okay. I think I caught up. The Speak Out program. Yes, very good. Speak Out program is another good speech therapy. Very good. Okay.
Looks like we're running out of questions right now, and I will echo Karen. Thank you, Dr. Hill,
Yeah, my
for
pleasure.
an excellent presentation. I'll
Thanks.
remind everyone that we record these programs, and it will take us a few days to edit out some of the early stuff before we actually came on the air. But we will generally get that done in about a week's time. So if you're interested in going back and watching the presentation, you can go to our website, which is Parkinson, no S at the end, parkinsoncincinnati.org. And if you'll look under our learning tab and then PDE to use, you'll see an archive of previous PDE to use, and you'll be able to access this one. So look for it in about a week. I would also mention that while you're there on that website, we have another tab called Moving, and if you look under Exercise, you'll see that we list about 92 different, about 92. I counted them. It's 92. 92 instances of Parkinson's specific therapies that are provided throughout our service area. And we have a pretty good sized service area that we work in. It covers West Central and Southwest Ohio. Southeast and East Central Indiana and Northern Kentucky. So we go as far north as you'll see exercise opportunities as far north as Findlay, Ohio, and as far south as Lexington, Kentucky. Those exercise programs are easily accessible. You can look by neighborhood to find where, if there's anything near you or what is near you. You can also look by day of the week. And finally, you can also look by type. I mentioned voice a number of times. We have a number of voice therapy providers throughout our area and in different types, LSVT Big, the Texas Voice Project, etc. And then the boxing, cardio, dance, and I'll just mention here, but I suspect we'll hear about it more in the next portion of our presentation today, and that is that these therapy offerings are typically a place where Parkinson's patients and caregivers can get together and have an opportunity to support each other. So it is not just a physical opportunity, it's also a good emotional help. With that, I will again thank Dr. Hill and
You have a hand up.
Yeah.
Mary Jo, did you have a
Can
question?
I ask just, it's going to be easier, I think, to ask than to
sure, go
type
ahead.
it in. I'm sure falling is a constant worry with people. And I've had 2 times where I've slipped out of a rolling chair. It wasn't that the chair was rolling, it was that I was reaching for something, shouldn't have done it. And that I'm in one now at the computer. These chairs have wheels on, but I'm on carpet. But you hear, don't sit, don't use a chair with wheels. But I can't find any recommendation for a chair, a good chair to use at a computer
Mm.
that doesn't have wheels, or even the only thing I got from somebody is obviously adjusting one that you can have your feet flat on the floor and to be lower to the floor. And then I've seen two where I think I've got two of them. I mean, they're hand-me-downs, but one has a wider base, and so that's more stable. But when I go into research, it's like they're showing me things for 500-pound people, you know. They're thinking I'm looking for something like that, but I'm looking for something more tip resistant. But I just feel like I need one with wheels that can move around, you know, while I'm twisting, I guess. But anyway, if you've got something to recommend now or later or whatever.
Yeah, no, that's a great point. I don't have any specific recommendations. The therapist might know more than I would.
Yeah.
Occupational therapy specifically, they're really good at any sort of like equipment or things around the house, so they might know, and the physical therapist might also know. But yeah, it's a common problem, the plop too. I mean, that doesn't sound like what happened to you, but people have stiffness in the muscles along their spine. So sometimes when they sit, they plop, and that can make some chairs more dangerous as well. So yeah, but I'll ask around. I'll see if any
Okay.
occupational
Yeah,
therapists.
because frankly, a chair with four legs, I think is more tip resistant or more likely to tip.
Mm,
At a computer. You got to be able to move a little bit. But anyway, if
yeah,
anybody's got any feedback,
yeah, I'll have to ask around.
thank you.
There was one more question in the chat too. Anna, if a person gets dementia after developing Parkinson's, is it always Lewy body dementia? The answer is no, it's not always. About like a huge number, like 70% of people that have Parkinson's disease also have Alzheimer's disease proteins in their brain. And we haven't figured that out yet. That can't be right, that people are just so unlucky that they got both Parkinson's and Alzheimer's. It seems to be a sign of a brain that is under attack. And so a brain that's under attack is clumping up proteins to try to maintain their brain cell function. So sometimes that's Lewy bodies, sometimes that's the Parkinson proteins. But the short answer is no. Sometimes people have Alzheimer's disease symptoms as well, but it's usually a combination of dementia with Lewy bodies plus Alzheimer's, if that makes sense. Okay.
I did see somebody else momentarily raised a hand and then I lost them.
Oh.
So I'll just basically throw it out. Do we have any other questions? And I suspect that if your experience is anything like my own, and I will raise my hand and say I have not yet been diagnosed with Parkinson's. But when I go to the doctor, I rarely get 20, 25 minutes of an opportunity to ask questions. I usually get about 15 minutes and then, here's the prescription, see you later. So we really do appreciate Dr. Hill giving us a full hour of presentation and questions and answers. We have a panel with, I'm going to ask Kevin Cox and Dan Burton and Elizabeth Grover to unmute their microphones. And they're going to talk about their experiences. I'll let Elizabeth do the introductions and get us started, but I would recommend if anybody needs a quick bio break, now might be the time. And then we'll take a couple of minutes to pause, and then we'll go ahead and get started with our panel presentation, what we call P2P, persons with Parkinson's to persons with Parkinson's. Dr. Hill, thank you so much.
Thank
Tell
you.
Maureen that we want a full report on how her morning went.
Will do. Sounds good, guys. Bye.
Bye now.
You.
Well, if you do need to take that quick bio break, I'll use this moment for those who remain to do a little bit of a commercial. We have a spring forum every year in April. This year it is, I believe the date, and hopefully Becky will correct me if I'm wrong, but I believe we're set for April 27th for our spring forum. It's held at the Manor House in Mason, Ohio. If you recall me talking about our coverage territory from Lexington to Findlay, Ohio, we took a look at a map and found that the geographic center of that is I-75 and Tylersville Road, which will dump you off into Westchester and then Mason. So it's been a good place for us to hold the event. We will open registration for Spring Forum next week. Once again, you can find that at parkinsoncincinnati.org under the Learning tab. This time, instead of looking for PDEDUs, you'll look for Spring Forum. And it's always a very informative event to entice you to come. We throw in some really good free food. So we'll encourage you to join us at that time.
Hey, Chris.
Yes, yes, Becky.
It's April 26th, Saturday.
26th, okay.
26th on Saturday.
Thank
Yes.
you. I confused that with September 27th, which is Steady Strides, which is our annual community get-together for folks in the Parkinson's community, where we do a 5K walk and run, and have a great time on a Saturday morning in this year in September. You should not be surprised to hear that we also do that in Mason, since it's convenient. We hope it's as convenient as possible to everybody in our area, and that is held at Corwin Nixon Park. Registration for Steady Strides will open up also in about a week. So we encourage you to come. That's a great day. Also free food. So we really do try and entice you to come along and have a great day. With that, Elizabeth, if you and Dan and Kevin are ready to go, Kevin, we'll need you to unmute your mic. There we go. I'll hand it over to Elizabeth Grover, who is Vice Chair of the Board of Directors of Parkinson's Support and Wellness. She may be the busiest person I know in terms of exercise therapy and working on a great life. So Elizabeth, it's all yours.
Thank you, Chris. When I started learning about Parkinson's and I was paying attention to this wonderful basics program, which we do every year, it occurred to me that there was one perspective that wasn't represented, and that was that the perspective of being a patient with Parkinson's. Dr. Hill gave you lots of wonderful information, but she didn't tell you what it's like to live with Parkinson's because she's never done that. So there are three of us this morning that are going to share our journeys with you, and we're going to answer in three sets of questions. I'll just tell you the questions to start with, and then we'll deal with them one at a time. The first question is, what was our reaction when we were diagnosed? And what were our fears and our expectations? The second question is, how has our Parkinson's actually progressed? Has our fears been realized or our expectations been fulfilled? And the third is, what steps have we taken to manage our Parkinson's? We think that the answers to these questions will help the people that are recently diagnosed to understand better what the future might hold. So I'm going to ask Dan to start first and answer the question, what was your reaction when you were diagnosed, and what were your fears and expectations? Dan Burton?
Yeah, I was diagnosed about 12 years ago. I was 48 years old at the time. And I had a feeling something was wrong. I had this pill rolling thing in my left hand. My wife was a nurse. And unfortunately, she was in California at the time taking care of her mother and stepmother who was dying. And I went to a man who was very wise, very smart, but had very poor bedside manner. And basically did some tests, and then he said, "What do you think?" And I said, "I think something's wrong." He said, "Yeah, something's wrong. You got Parkinson's disease." And I said, "Well, what does that mean?" And he says, "Well, it means you're going to continue to get worse in these areas." And I said, Well, no, realize this was 10 years ago. There's a lot that's happened since then. And this guy used to rely a lot on his assistant, I was told, and his assistant was on vacation at this time. So he just said, well, you got a number of stages. You're going to get tremors in the other hand, then you're not going to be able to walk. You'll be a wheelchair, and then you won't be able to swallow, and that will be the end. And I said, how much time do I have? He said, no, you're a young man, maybe 2.5 years between each step. I said, you mean I have 10 years left? He said, give or take, that's about it. So I walked out of that office, shook up, and just as I was walking out, he said, by the way, I can give you medicine if you want it. And I said, what medicine and why? And he said, my assistant will write all that to you. You'll get it in the mail. I said, okay. So I drove away with my wife's out of state in California, and I had 3 sons. And all I could think of was, I'm going to look like Michael J. Fox, and my kids are going to be embarrassed to be with me in public, and my life is ruined. And it took a lot of just time to settle down and talk to people who knew what they were talking about. And Maureen really helped me. Maureen, and they finally lined me up with Dr. Duker, who's a great doctor, and he's been very helpful to me. So my original diagnosis was a bad experience. It wasn't until my wife came home 5 days later we were able to talk it through, and she's a nurse and she knew a little more. But I'll explain later. The group of people that I didn't know I needed, or what I needed, was people who have Parkinson's that I could spend time with. And so that first start was pretty bad. My first fear that my children would be embarrassed to be with me in public, and that I would quickly become like Michael J. Fox. Well, it's been 12 years and I'm still very active and still working, and have started to have some more progression in recent months, but mainly in my voice and some other things. But I'm living a very good life still. So there's the first 2 questions for you, Elizabeth.
Thank you, Dan. Kevin Cox, can you answer the question, what was your reaction when you were diagnosed, and what were your fears and expectations?
Dan, you hit the nail on the head. I can almost picture the same doctor. I'm convinced he's at UC, is he? Was he
Yeah.
at UC?
Yes,
Yeah,
sir.
I know who it was. I'm not going to say names, but boy, because I had exactly the same thing happen. I was 49. My wife was pregnant with twins. I went in for a annual physical. I always make a list of things to talk to doctor about when I go in for a physical. And so one of the things was when I washed my hair, my left arm would move slower than my right arm. So I brought that up, and the doctors became very concerned about that. Show me how you do that. And I showed them. They sent me off to get, I think it was a CAT scan of my brain or something like that. Then they said that the first thing that came back is I had had a stroke. Oh, that's pretty bad. A stroke at my age? Oh my God. But they sent me off to this doctor that I'm convinced the same as you had. And yeah, it's teaching hospital, right? So he had somebody with him. He said, let me show you something. Mr. Cox, can you go out and walk up and down the hall? Sure. So I walked up and down. I heard him say, see, his arm's not moving. It's not swinging right. Okay. So what's that mean? Anyhow, I come in, he says, do you have any other symptoms? I mentioned the hair washing thing. You have Parkinson's. Okay. I'm going to give you a referral to a movement disorder group. So that's pretty much all I got from him. And went up and met with Maureen in her group. I shouldn't say Maureen because technically, it was a doctor. I forget who it was at the time. He's moved on. But right now I see Kara Jacobs and Maureen. And Maureen was a godsend. I mean, she really was. So anyhow, my concerns were, biggest concerns, what will my twins remember me as? Will I be some invalid in a wheelchair that's drooling on myself and everything? Because I know that it was research that I stopped. I played the ostrich. I want to know more about my future. So anyhow, bottom line is that's sort of, you hit the nail on the head though. That guy, I'm glad, I don't know if he's around though, but I'm glad I'm dealing with Maureen in that group now because the movement disorder group is awesome.
Amen.
So now the one I will say, it's been interesting. I did a little bit of research after contacted to be involved in this and in the research about this. The one thing I watched a couple of these videos in past years on the patient stuff. And the bottom line is that when we went through that process, everybody talks about support. And my ex-wife, who was the one who had twins at times, ended up dumping me because I ended up with some compulsive behaviors. And she didn't believe they were compulsive. She believed I was just a bad guy. The doctor had called her and everything. So we ended up going on separate ways, divorcing, so forth and so on. Now I have a wonderful woman. I'll tell you more about that later on. But that's sort of my story. Okay?
Thank you, Kevin.
Yes.
Now I'm going to answer those questions for myself. And you can hear what my experience was. First of all, I did not expect to get Parkinson's. I expected to get cancer because there's a lot of cancer in my family. My mother and all 3 of her siblings have had cancer. My mother contracted breast cancer at the age of 29 and died when I was 6 years old. Since breast cancer has been strongly genetic, I always expected I would get breast cancer. So when I was diagnosed with Parkinson's in 1998, I said, wrong disease. I wasn't prepared for Parkinson's. I did, by the way, eventually get breast cancer, but I'm in remission from that, thankfully. So naturally, I was surprised, but not completely shocked about being diagnosed with Parkinson's, because both my maternal grandparents had Parkinson's. I knew something about it. So my expectation is that I would be like my grandparents. My grandmother, who lived with Parkinson's for more than 15 years, died at the age of 90, was confined to her bed for the last few years of her life. My grandfather spent his last few years refusing to take his PD medications and shuffling around the house. They were, by the way, divorced long before they were diagnosed and never shared their experiences of Parkinson's with each other. But I thought I knew a lot about Parkinson's because of this experience with my grandparents. But it turns out that as I was diagnosed at the age of 39, I was young onset, and that people that are diagnosed before 50 are considered young onset. And people with young onset Parkinson's tend to progress more slowly and sometimes have more or at least different complications down the road. So when I asked the doctor who diagnosed me, what the progress was to be, I expected the worst. But he told me that within each individual, Parkinson's tends to progress at a constant rate. This is what Dr. Hill was talking about. But that rate is different for every person with Parkinson's, so we would not know until I had been observed for a while what that rate would be for me. So I felt the fear of the unknown. Another expectation was that I would not be able to be a good mother to my 3 children. That's also come up before. And they were ages 14, 12, and 9. At that point, I was a single mom and did not know how quickly my abilities would decline. But my children were at least initially more help than a burden because of their attitude. Their reaction to my diagnosis gave me hope. My 9-year-old assured me that things would be okay. When I said I would miss things like taking my grandchildren to the zoo, she said, "We can park push your wheelchair at the zoo, and since you're in the handicap parking permit, we'll get the best parking space." So she was optimistic about that. Now that 9-year-old is 35, has 2 daughters of her own, and I have been with them to the zoo, with all my grandchildren to the zoo. So that was an expectation that I didn't need to worry about. So after she said that, I felt inspired to focus on how I was doing each day and not look too far into the future, because I realized that I might be worrying about things that would never happen or I could deal with when I got there. Now, question number 2 is, how has your Parkinson's progressed and were your fears or expectations realized? Dan, can you answer that for us?
My Parkinson's didn't progress at all for a while. I didn't take medication for the first couple of years, and then got on medication, and even then it was not progressing much at all. Actually, now that I've had it for 12 years, the last 6 months I've had more progression than I've had the first 12 years. But I think a big part of that is Maureen told me about getting exercise, and I said I exercise a lot. I ran a marathon, Cincinnati, the Flying Pig, the year after I was diagnosed, just to say I could do it. And I don't run that much anymore, but I was doing a lot of exercising at the time, and I said to Maureen, I'm not sure that kind of working out with people who, stumble and can't stand up and stuff. I don't think that's exercise for me. I thought it was more just sitting in a chair or something. She said, I think you should try it out. Well, I didn't. The next time she saw me, she said, have you been going? And I said, no. She walked out of the room and came back. She said, well, you've got some money on account there. It would be a waste if you didn't use it. So I went to Forever Fitness, and not only did I need the exercise, I needed the community that was there. And that's made the biggest difference for me is the community, for people to talk to. And like you said, some of us don't exercise real well unless we got a friend asking where we are. That's really helpful for me. So I end up going there twice a week, soon to be 3 times a week, going to Forever Fitness. I know there's a lot of options out there, but they've changed my life. And I told a friend who was recently diagnosed, I said to him, I know you don't like exercise, but if you're not going to exercise, you're going to shorten your quality of life. And he said, I'm just not into it. And I said, I don't care if you're into it. If you're into your family, if you're into those around you, you better start doing it because it'll make a difference. And so that's what's I think kept things at bay for me for so long. And even now I've got to keep making exercise a priority. My wife does. She considers that untouchable time on her schedule each week.
I can vouch for that. Dan, there's a Friday noon class that Dan and I are often the only two there.
Yeah.
We were there.
That's right.
Thank you, Dan. Kevin, how has your Parkinson's progressed?
Well, I was diagnosed in 2010, it's 2024. I had no idea. It was very much the same thing, glide slope. I sold that type of stuff, and but it was progressing slowly. In fact, over the last year, they haven't really seen much progression at all. I think my numbers have stayed the same the last couple of years. But the bottom line is, for me, it was DBS that was a savior because I started to get a lot of dyskinesia. I thought in 2020 I was going to have to quit work at that point. I'm retired Air Force. I was working for Northrop Grumman at the time down in Cincinnati. So I ended up getting the DBS. And I don't know if anybody here has had DBS, but what happens is they put there's 2 surgeries put in. One, they put the wires in, and then they put the battery pack in, and later on they turn it on. Turning it on was with Maureen, again, the angel for many of us, I should say. She turned on, and the stiffness and the tremors, it was like somebody had thrown a switch. I mean, seriously, it happened that fast. And so, bad side of what I went through, again, I told you earlier I played the ostrich. You want to know what was going to happen to me. So I think it was 2021, something like that. I was out in Vegas with my brother. I went out because I was thinking about quitting work. No, it was it had to be 2018 when I did this. 2018, I went out to visit my brother, Vegas area. And I was thinking I was going to have to quit work because my Parkinson's was progressing and tremors and everything. And I was having a lot of depression. In fact, the director of engineering at Northrop would come in and talk to me. And, how's your day going, Kevin? And I said, I hate my job. So I go out and talk to my brother, mentioned him what's going on. He's like, you got to extract your head from that dark place you have it, Kevin. You got depression or something. What are you talking about, Sean? I'm telling you, you got depression. So I called Marie in between my crying and screaming things out. I said, Kevin, I ask you every appointment, do you have anxiety or depression? And you always say no. And so, anyhow, she sent a prescription out to Vegas for me to pick up it out there. I took one. She said, "Oh, but it may take 30 days." I'm like, oh, it's more of this. I don't know if I was so low on it or if I was lucky or what, or maybe it was a placebo. Who knows? But I took one pill that night, went to bed. Next morning, I was much better off. So that's a big deal. And then I guess the last thing, it was, by the way, when people say that they have anxiety, it's not fear. It is, well, I shouldn't say that. It's fear, but not the way I thought of it. It's losing control. I could control something. So that's what my anxiety was. And not knowing these terms these people throw around, because again, the ostrich doesn't help me much. Not knowing the terms is critical. You have to know when they ask you, are you having this? You're having compulsive behavior. You're having depression. You're having anxiety. What's going on? that's critical to be able to answer those questions, knowing the definitions. So, and the only other thing I can say has happened in all this is I met my wife, current wife, and she's awesome, Sam. She's taking my daughter to lacrosse practice today so I can do this. But we got married in 2022. 2022. And had a good life. And then sometime early the next winter, I think it was, she knows my mood was changing. I was being more aggressive, more angry and stuff. Well, what I found out there in that, because she started going to appointments with me, she wanted to see what the heck went on in these appointments. So we went to the appointment and they said, she started describing my behavior with Marie, and she's like, oh my God, Kevin, we got to get you off some of this. Basically, you're taking too much meds, way too much. It's causing you to act out that way. And I'm like, how do you know that? And she's like, well, we put the DBS and we backed things off. We clearly didn't back it off enough because you weren't telling us about these problems. I didn't know I had a problem until Sam said I'm yelling too much. So, yeah, Sam is my support system. She keeps on me, make sure I do stuff. I will say the exercise, I run it or walk, swim, or I walk, run, and or swim in the winter 5 days a week. Walk, run is 60 minutes, and the swimming is at least 30 minutes, 1,000 yards. And then I do 4 miles of the walk, run thing. So I'll walk 2/10 of a mile and run 1/10 of a mile, trying to get myself back in after being fattened up over Christmas. And it makes a world of difference for on top of the medications being dropped down, just burning off the energy and stuff and the frustrations, daily frustrations, is a big deal. Now, I will say one more thing that I think everybody, well, I won't say that. I thought it was frou-frou. I thought it was the yogis out there, didn't know what the hell they were talking about on things. But one of the people I dated for a while before I found Sam, she told me, Parkinson's, I need to change my diet. I need to start doing yoga, meditation, all this. No, just because you get a master's, that doesn't mean I need to do it. So I was home and I was watching a Netflix thing on not biometrics. It's a basic biome, taking care of your biome. I found out that there's a high correlation between people who have biome, don't have poor diets, which causes a problem in the biome, and Parkinson's. And so she's now making me drinks of morning. This was her, I think she called it an orange blueberry for me mix this morning. And between that and taking chia seeds, which, I also have chia plants, chia seeds, flax, all the other stuff that's good for you. I'm trying to reconstitute the biome. And it'll be interesting to see what that does long term, because I think maybe between the exercise, because that got helped solve my constipation problems to a large extent, and this, that I'm hoping to stave this damn thing off. We'll see.
Thank you, Kevin.
Mm-hmm.
For me, what my fears and expectations were realized. Well, every Parkinson patient is different, but there was no guarantee that your PD will be like mine. But I have found my Parkinson symptoms to be fairly manageable in a way I had not expected. The progression of my PD has been quite slow, and so I've been able to adapt along the way. Some of my most troublesome symptoms are difficulty with walking and balance, and lately posture has been my most difficult symptom. I have adjusted to increasing severity in each of these by targeting the symptoms in my exercise and even my everyday movements. For posture, I incorporate back stretches into my exercise routine, and whenever I walk, or even when I'm sitting, I try to find a vertical line, like the edge of a window or the edge of a door, or a very straight tree or a railing or something, and line myself up so that I'm in line with the vertical line. I force myself to always take hiking poles when we go hiking, which my husband and I love to do. It's not easy to control and my tendency to take small steps or to hunch over or any of those other Parkinson's things. You have to fight it. But when I work hard to correct these deficits, I can make a difference. But being this vigilant, however, is exhausting. I think you'll all agree with that.
Mm.
Okay, our third question, and we had some bleed from the question 2 to the question 3, but because they're sort of, they follow so closely on each other. The third question is, what steps have I taken to manage my Parkinson's? Dan, can you fill us in on what steps you've taken?
Yeah. Well, one thing I said was exercise. I still say that's big, and that's also allows me to be around from positive people who have Parkinson's and are trying to live with it and work with it. And another thing is, my wife is a nurse and always knows what's best for me. And she will often ask, have you taken your medicine yet? Which my response I want to say is, give me a break. I'm a grown-up man. Leave me alone. And then I go in the other room and take my medicine. And, but I made a decision. She didn't suggest this. Every time she asks if I've had my meds yet, I'll say, yes, I have. Thanks for asking. And I always have to say, I say that verbally because she's always trying to help, because I remember 4 times a day. And if I don't take it regularly, it messes me up. You got to take your medicine on a consistent basis. I apologize. The UPS guy goes by, my dog's going to go crazy. So getting in my medicine regularly, that involves my wife helping remind me. So I say thank you to her for that. I think I left it past here for a second while I keep the dog out.
Okay. Kevin, you want to answer what steps you've taken?
Well, I always sort of talked about the exercise.
Mm-hmm.
I will say I'm an Apple fan, so the health thing on Apple helps a lot, because I put what meds I'm supposed to take what times, and it'll go off on my phone and my watch. If I don't get to it within a half hour, it gives me a quick alarm. So even if I have my phone set not to disturb me, it'll disturb me anyhow. So that is a good technique. I sort of go off some of one of the things Dan said when Sam says, have you had your medicine yet? She's normally seen something. And so I have to go take my meds. So she helps with quite a bit. My family, my kids are very supportive. That's important. Although my kids really keep pushing for this handicap sticker, and I keep refusing it. So we'll see how that plays out. Let's see. I don't know. I think that's about it. I mean, I've been lucky. I've been blessed. And seeing between Kara and Maureen and making sure that I listen to them and they take care of it. And Sam, I think I'm in good hands right now. But the support group I'm seeing here might be another tool I should put in my kit.
Thank you, Kevin.
Mm-hmm.
Dan, you want to finish up?
Yeah. A couple of things I want to add was that I'm still driving and I'm a fine driver, but I've recognized my wife as a better driver than I am. She always thought that was true. I don't think that was always true. But she has not had an accident in 45 years of driving, so that's a pretty good record. So I've realized now when we go places, I let her drive mainly. And I've had to step back a 3/4 time at work, because last time I was at the appointment, Maureen walked in and said, okay, what's going on in your life? I see 3 things in your posture and in what you're doing right now that shows me you have stress, too much stress in your life. And I realized I can't do what I used to do at work. I can't do all this thing. I'm down to 3/4 time, and they've allowed me to keep my insurance. So I've had to face some things like that just to make some adjustments. And my family's noticed the difference in me only working 3/4 time. It's giving me a better quality of life at home. So little things like that.
Very good.
Can I add a couple more things he triggered?
Sure.
I can't drive worth crap. In fact, I went out to Johns Hopkins about a year ago. Sam wanted to see if there's better care for me someplace else. So my stuff's universal. I'm retired military, so that's healthcare there. I have additional from Northup, but then when I got Northup, I had max out of pocket every year, max for catastrophic of $3,000. Now I have Medicaid cover kicking in on top of that. So whatever TRICARE doesn't cover, Medicaid covers, and vice versa. Or Medicaid, whatever Medicaid doesn't cover, I should say TRICARE covers. But when I was at Johns Hopkins, they told me that, they asked the question, do you curb your car? Yeah, how do you know? There's a lot of Parkinson's patients apparently turn corners and have a judgment issue, and they turn the car too tightly, they'll curb the car. Unfortunately, I drive a Tesla. Well, unfortunately, it's bad on the rims, but the car drives for me. So that's how I handle the driving on it. It's a lot safer than I am, and Sam's a lot more comfortable. She can sleep when the car's driving and can't when I'm driving. So those things out there as well.
Okay, thank you, Kevin. And for me, the first and most important step that for me that I've taken to manage my Parkinson's is exercise, that has been re-echoed throughout the program here. When I was first diagnosed, I had a friend who set up walking buddies for me, and I tried to exercise 2 or 3 hours a week. Over the years, I've added more and more exercise opportunities. I've done Tai Chi and yoga. I try to take a walk or a hike almost every day when the weather permits. I attend Parkinson-specific exercise classes 3 or 4 times a week. I work out with 2 different personal trainers who specialize in Parkinson's, and I attend Parkinson-specific dance classes and boxing classes. Usually I exercise more than 12 hours a week. Exercise makes my body produce more dopamine. It gives my muscles the strength to combat the physical symptoms of Parkinson's. It improves my mood, and the stretching part of exercise helps combat the rigidity. And Dr. Hill told you the biochemical reasons that exercise is good for Parkinson's. It continues to be the only thing that's shown to slow the progression of the disease. So I truly believe that the reason I can manage my Parkinson's is that I have slowed the progression by this exercising. And when the rate of decline is slow, I can adapt along the way. I get used to each new symptom, and by taking them one day at a time, I can deal with it. Another step I've taken is to learn as much as I can about Parkinson's. I have attended conferences and webinars and meetings. I've read books and articles. I've worked to make information available for others with Parkinson's as well. As I learn more, I have also learned that many families affected by Parkinson's need more information and support than they are getting. This has led me to become involved in the Parkinson's community. My involvement in the local PD community has taken many forms. I have served on the board of Parkinson's Support and Wellness for over a dozen years. I served on the program committee for nearly 10 years. I've been instrumental in starting the exercise classes, the Dance for Parkinson's program, and the Steady Stride Singers, which is a singing group for people with Parkinson's and their friends and family. I have started programs for newly diagnosed folks. I won the Sunflower Victory Award in 2018 for my contributions to the Parkinson's community. I find this community involvement very rewarding because it keeps my brain working while at the same time sends me an abundance of gratitude. It also helps me stay connected with others. And the socialization is very important. Keeping that social network active has been especially difficult in COVID times, but it is very important. And a recent study actually found that the single best predictor of decline in Parkinson's is a sense of loneliness. That was amazing to me. Single biggest predictor of decline in Parkinson's is the sense of loneliness. So we have to avoid that at all costs. You think the social part is just kind of the fun stuff, but it's not. It's really essential to our well-being. Finally, though it's easier said than done, I think perhaps the most beneficial step I've taken is my intention to keep a good attitude. Attitude makes a huge difference in the amount of stress in my life. I recently moved to a senior living apartment, and when I take the stairs to our 3rd floor apartment just for exercise, I find that fire doors that I must open are very heavy. First, I thought, oh, these doors are so heavy. But then I changed my tune and I thought, hey, I'm strong. I'm so strong I can open these doors. This change in attitude makes it much easier to open these doors. Just believing that I am doing something proactive gives me hope that I can continue to stand up to this disease and that I won't let it completely control my life. And those are our pieces of wisdom, Chris.
Thank you, Dan. Thank you, Kevin, and thank you, Elizabeth.
We'd be glad to take some questions if there are any.
Yeah, I was going to say now might be a good time, and if it's easier for you to unmute your mic and just ask your question, feel free to do that. We don't need to use the chat once we get to Q&A, but like to use it more while we're doing the presentations. I would also add that Elizabeth has written about her journey with Parkinson's, and believe she has a new edition of her book, and you'll be able to purchase that book at our spring forum in April, and then we're also going to continue to make that available via our website after spring forum. So check it out.
Yeah.
She,
Yes,
she,
got it.
she writes a good book. It's a good read, I can tell you that. So questions, observations, comments. Somebody's going to say, I'm hungry. I have
I want to say, one other thing is that, you know, I didn't want to be known as that guy with Parkinson's. I didn't want to be labeled by it, but it's part of my story, but it's not the end of my story. And not everything is tied to Parkinson's. Everything you get, my hands are sore. Well, my mom and dad both have arthritis. Everybody's got stuff. We happen to know what ours is. And kind of like Kevin, I didn't like looking into stuff because I didn't want to know what my future was. I let my wife do research. And I still don't like to do a lot of that because it depresses me. So I let her do research, and she does recommendations, and I stick to my part so I can keep a better attitude. So I figure, we all, and no Parkinson's is the same. All the friends I've got that I exercise with, they've got stuff that I'm not dealing with. I've got stuff they're not dealing with. Most all of us deal with sleep issues. So we compare stories there, but I just want to say that everybody's got something. Everybody's carrying burdens. And so I try not to get carried away with mine. Mine's worse than somebody else's. I'm still able to function well and live a good life. And the important part is keeping a good attitude, like Elizabeth said.
I wanted to comment, Dan, you made a reference earlier to the exercise that you do and the fact that when you go to the Parkinson specific exercise programs, that in addition to the physical benefits of doing that exercise, there is a benefit in the community that you experience there. One of the things that we haven't talked a whole lot about is the ability to find that community specific to sharing with each other, and support groups can do exactly that, give you that sense of community. Also a good place to not just share what's going on, but what works.
Yes, right.
And very similar to what we've just experienced today. And again, I thank our panel for it. There are, I mentioned 92 specific exercise programs that are specific to Parkinson's disease that we have listed on our website. There are also a list of support groups, both in person and virtual. And we list them the same way as we list the exercise. So you can look in your neighborhood, you can look by day of the week. I know that we have a number of people that attend a virtual support group. We do 2 of them on, I believe, the second Monday of the month, and one for caregivers and one for patients. And there are many people who attend those and also attend one in their neighborhood that's in person. So we would encourage you to find a group that that you feel good in and can share and learn from that. So I thought that was telling, Dan, when you mentioned that the sense of community was an important factor in going to a Parkinson specific exercise program.
I just say thank you to all of you and sharing your experiences. And it was wonderful. I really, really appreciate it.
Thank you.
Any other questions, comments, observations, clean jokes? All right then. Well, we've spent more than an hour and a half together. I appreciate everyone. We actually had very little drop off after Dr. Hill, so appreciate everyone spending your time with us on this wonderful rainy Saturday. Look forward to seeing you again next month. Keep an eye on our website for next month's program and the opportunity to register. We'll open registration again next week. With that, wish you all a wonderful Valentine's weekend, and we'll see you soon.
Thank you,
Thank
Chris.
you.
Thank you.
Thank you, all the panelists.
Thank you.
Thanks, everyone. Bye now.
Bye.